Today we have a couple presenters, Sandy Stokes and also Rebecca Sudore, who are going to be speaking with us about end-of-life care discussions and advanced care planning with Chinese patients. So just as far as context, for the past couple of years, I've had the opportunity to work with the Mary Center for Education and Palliative Care, which is a group led by Mike Rabo. We've been working to provide palliative care education for the Mount Zion community professionally, but also for our patients at DGIM and Mount Zion in general on topics including advanced care planning. So I think as folks know who are part of DGIM, and we have many others sort of joining us from various other divisions today as well, but at the Division of General Internal Medicine, we have a very diverse patient populations, many who have limited English proficiency. And so around 10% of all of our patients list about another language other than English as their preferred language. And about 40% of those, which makes up about 1,000 patients, list the Chinese language as their preferred language. And then when we look specifically at our older populations, this number goes up to about 20% of our 65 and older patients having a limited English proficiency, and half of those being Chinese language speaking. So this makes up a very large proportion of our patient population. And I think the older patients with limited English proficiency has became particularly salient, I think, recently with the COVID vaccine rollout and difficulty in making sure that we get our most vulnerable patients the vaccine with their linguistic and technical barriers. And we saw a lot of our providers at DGIM amazing advocacy and activism to get these vulnerable patients equitable access to the vaccine. And as far as advanced care planning, this is, while advanced care planning is relevant for all patients at all ages and stages of life, it's particularly important for our older patients. And so is something that is certainly difficult for us to do, one, in our busy clinical practice, but also when it comes to people who we are not speaking in the same language, to do this cross-culturally and cross-linguistically can be particularly difficult. So we have partnered with the Chinese American Coalition for Compassionate Care with a grant from the Mount Zion Health Fund Community Partnership Grant to bring some of these resources to our Chinese American patients at DGIM. And we are very lucky to have Sandy Stokes from our community partner presenting to us today. So an introduction, Sandy is the founder and board member and former executive director and board chair of the CACCC. She's an internationally recognized speaker and has been providing a lot of end-of-life education and training for Chinese community and also health professionals. Under her direction, the CACCC has developed many educational tools in Chinese regarding end-of-life care and advanced care planning. And she will speak to some of these efforts and how and their relevance to our DGIM community today. She is has been awarded the American Cancer Society's National Lane Adams Quality of Life Award for her work with the CACCC. She has also received the AARP's Inspire Award in 2011, as well as the Compassionate Care Innovator Award for the Coalition of Compassionate Care of California, and also the Influencers in Asian by Next Avenue. And so she continues to serve for the advisory board for the Chinese Health Initiative at El Camino Hospital, and also is the National Hospice and Palliative Care Organization's Diversity Advisory Council member. At the end, we're going to also have Rebecca Sudore chime in and talk about her project at UCSF and at DGIM as well. Rebecca, many of you probably know also, is a geriatrician and a palliative medicine physician, as an advanced care planning researcher and a professor of medicine here at UCSF. And she directs the Innovation and Implementation Center on Aging and Palliative Care Research for Vulnerable Populations. And she is the creator of the Prepare for Your Care Advanced Care Planning Program online, and also the easy to read advanced directives, which many of us are very familiar with in our practice. And she has been working with the Office of Population Health and DGIM, so she will be joining us as well. So Sandy, go ahead and take it away.
Hi, everyone. I'm going to do my best to have everything I'd really like to share with you in this time. Otherwise, all the information, you can go to the CACCC website to get more details. So this is our objective today. I promise I'll do my best to cover everything here. I want to start with the movie here. I don't know how many people actually saw The Farewell, probably a couple years ago. I love all the actors there, particularly Aquafina. She really represented the people in the younger generation in States when she faced the family dynamic, particularly the cultural language issue here. If you already saw the movie, that's great, you know what I'm saying. If not, then please get a chance to watch it. It's really worth it. In that movie, I think I just want to point out one thing. When the grandma in the center diagnosed with terminal ill cancer, so everybody decided to all get together to see grandma, Nai Nai, and to avoid suspicious of her, because they decided not to tell the grandma that her condition. So they say one of her grandson got married. So they fake arrange this wedding. So everybody planned well. Aquafina have a different idea. She think we should let Nai Nai knows that. So during the conversation, I think the one behind her is her uncle. The uncle says something I think really can help us to get started today's talk. The uncle says, you know, you are the ABC, American-born Chinese, and your belief system is very westernized. You believe not to tell the grandma, you tell the truth, right? But to us, it's different, because what you do is you are trying to relieve your own burden by less guilty, by tell grandma, so grandma can going to make the decision. But for Chinese culture, it's different. We as a family, we work together as a team. So by holding the diagnosis, actually we are showing our love to grandma, because we're willing to carry the whole burden ourselves, not the grandma. So that's really different. Even I'm a Chinese, I don't think this way anymore. Then I say, yeah, maybe I've been in States for too long. I miss some of the Chinese culture here. When we're talking about end of life, that's quite a lot of things we can talk about. And later on, I know that Dr. Sudore will share more with us. But this is just a few things that we are challenged right now with all the resistance for Chinese community, particularly senior, to talk about particularly the CPR DNR, or the services such as hospice and palliative care and other issues. So we know that in UCSF, I know it's a high percentage of a Chinese population, but I don't know what's the percentage. So you can figure out in your department. And that's the reason we decided to share this from a Chinese American organization, what we saw and what we did so far with everybody. So this is the photo I took when I went to Wuhan, China, a couple years ago. You probably can see that something's different here. We're missing a number. Since you all mute, so I just answer for you. We're missing number 4. And that's one of the language part here. If you don't know Chinese, for the sound is like a death. So normally in the big building, you don't see number 4, not just only in the hospital. We don't put the number 4 there. So you know the Chinese culture is deeply affect our society day-to-day work here. We started Chinese American Coalition for Compassionate Care for that reason, because this is our vision. Okay. The most important part is we decide to use the model of coalition model, original from Coalition for Compassionate Care of California. And we are partner with them. We really believe the coalition model can really help us to push the Chinese end-of-life movement. So starting 2005, we invite all the community leaders, agencies. We train the volunteers and the caregiver. We partner also with all the hospitals such as UCSF. So everybody can come in here to the coalition and contribute what they can do to support us to better serve the Chinese community in end of life. So what service we have is a lot, so I'm not going to read everyone, but throughout the presentation, I will share a little bit photo with you, okay? Several important one, of course, we developed the materials. All the materials you can find in our website. The newest one is the conversation project you can see in the bottom. And also we do quite a lot of patient visit through our partner agencies, such in Northern and Southern California and New York. We do the Heart Cafe and other services. The most important part is we use the media to help us, including this UCSF program, to let people know the activity we are having. We also do a lot of community outreach and education program. This is our hospital, the Chinese ambassador program. What we do is we train our volunteers and they will become our partner agencies volunteers. So when they serve their patient in the hospital, they carry the badge of their hospital. And this we show some is one in Southern California. And the right side is El Camino Hospital. That's original. We started the program back in 2014. We also go to New York to provide 30 hours volunteer training twice. And also we work with their local hospitals, hospice, and other local community leaders. So for the name, we say Chinese American Coalition. Definitely we serve in states. But also very soon we realized that we have many Chinese American here. Their families still in their original countries, such as China, Taiwan, Singapore, so on. So this is one of the studies showing that what's the shortage we have for China have the palliative care or hospice services. That create lots of issue because we train a lot of community, either volunteers or the community in general. But when their loved one in China, for instance, they couldn't, number one, find many of, hardly at all, of a palliative care or hospice unit, for instance, or the services. So we starting 2017, we went back to Wuhan, China, provide the training for majority of the nurses. And we also have a doctors as well. In 3 years, they've been very, very well developed throughout the country. So until the COVID-19, we decided to use the virtual services provider training. And this is one of the Hubei province, one of the hospital. We did mindful self-care for our health providers. So since then, we have been doing virtual services for all of our activities. Talking about the language, we just want to quickly mention that all the Chinese translation or interpretation can be very, very confused and challenged. For instance, hospice care, you can see at least 4 different translations for the hospice and 5 for palliative care. And then don't mention that we have a simplified Chinese, right? And the traditional Chinese. So it's very important for unified the same translation. So we work with NHPCO since 2005, actually before then. So we already formalized the terminology for end-of-life care. You can go onto our website, download our glossary. You will have see the Chinese and English glossary there. Simultaneous interpretation, it becomes very important for our meeting, particularly our joint meeting for the membership, because we have people not speaking Chinese at all. We also have people who don't understand English as much. So we rely on our volunteer interpreters team to help us. Then we work with some hospitals such as San Francisco General Hospital, help them to train the interpreters how to better use this terminology and understand of the end-of-life focus issue a few years ago. Also, there's a very important item here is the religious affiliation, because Chinese, we have this, I would say these are 5 different religions being practiced in probably all over the world of Chinese community. Number 1 is a Buddhist, and then Taoist, and others such as Catholic and Protestant. Of course, the majority of in America, we practice more of Protestant and Catholic. So I've been realized there's more and more Buddhist chaplains in the hospital, which is wonderful because religion is very important in end of life. I gave you an example. This is our one of our heart-to-heart cards. This is a heart 9. It says, after I die, don't touch my body for whatever the hours. Some will say 8 hours, some will say 48 hours. So that sometimes can be challenge for our health provider who do not understand why. So this is particularly for Chinese and also the Buddhist Chinese, because they believe that after doctor pronounce of the loved one's death, no breath, no heartbeat, doesn't mean the person is not there anymore. It just we cannot communicate with them anymore. So that's the reason family member will insist to not to touch the body at least for 8 hours. We will have a more, I think I did several training for one of the Oakland, that's one hospital, I forgot which hospital. We did that for the chaplain because they have a wonderful chaplain team there. but not many people practice Buddhist. So I will share more for when we talk about the heart-to-heart car. So CACCC, we are 100% volunteer-based organization. It's a nonprofit. Our job is doing some patient support and also education and community outreach. So one of the big focus is the community ACP education. We find out that most important part for everybody to start a conversation in advanced care planning is the better communication, either tools or the effort we put in there, either for health providers and patients and their family members, of course, the volunteer as well. So this is the one we developed back in 2014. It's just like a poker card. Only thing is in the center, they have a focus with the concern related to end of life. So this is the 4 different suits here. You can see, can easily find which suit you want to focus with. This is some example, okay? So the card, there's 5 different ways to play the heart-to-heart cards. The one of most well-known way to play is heart-to-heart cafe. We use the heart-to-heart cafe as an environment to help Chinese American be able comfortably talk about the ACP. And this is an activity led by our trained facilitators. During the cafe, people eat the pastry, drink the tea. Since we are no longer able to do face-to-face, we will ask people to take it easy, stay at home, get a cup of tea, and we can play the card. Okay. This is the one is most excited result we find out about a year after it, back in 2015. We find out, we ask people to pick 3 top cards they will pick is most important for them. And we find out the spade 3 is the one most important for most of our people out of 2,000 plus Chinese American is I don't want to be kept alive by machine. When we started this, we did the first ones in City of Hope in Southern California. When we did a poster there, all the people, the doctors and the health provider, they came by, they just say, sounds interesting, but this is not right. Because as our experience, Chinese in the hospital, they are the most, the population who will require and ask the doctor to put the machine on or do the CPR or feeding tube. Even the patient only have hours to go. They will insist to do that and not to remove it. So that get us very happy to see this because the people who coming to the Heart Cafe, they are the people who actually pick the car for themselves, okay? But then in the hospital, the situation is different. Who make the decision? You can think about that. Probably majority are the family member who want to make a decision for the loved one because loved one no longer to talk. We use this funding to share in the community, let them know, be responsible for our wishes to help our loved one. This probably be the best gift you can give to your loved one. If you can have the ACP ready, your loved one don't need to make the difficult decision for you and never know what decision you want them to make. So here is the grant we had received from UCSF. And during this 1 years of partnership, we have quite a few activities already went through. We still have quite a few to go. This is the one, if any of you interested to experience a Heart Cafe, we're going to have a 2-hour Heart Cafe set for this Saturday. You can take a photo here and sign up to RSVP this. This is the one of the very few English cafe we will host, probably once a year or once few years. We have English one because most people who can speak English, they will go to different routes such as Go Wish Car would be very popular one as well. And this one will be only by request by the health providers. So this is the one. And you can see through our partnership, we find out from one of our cafe, we did in Chinese. You can see we have a very good result here. People will recommend, and then also some of them already complete AHCD. Some of them will recommend, encourage a family member to do that. Actually, it's 100%. And you can see the middle one. Whether I want my doctor to talk to me about ACP. I know we are not only a palliative care provider here. We have lots of people from gerontology department or general practice, PCP here. You can see this is a myth. People think Chinese don't want to talk to the doctor about ACP, their wishes. Actually, they do. Probably through the proper interpreters or through the support of trained volunteers. You can easily to connect us with your family member or patient self to talk about how to complete the AHCD. So we can talk about more here. This is the question we ask. You can see number 2. I want to participate in other activity to learn about hospice and palliative care. And this is a very important information for us. Really can clear a lot of the barriers and misconception about how Chinese Americans look at the end of life. Because after all, with the Chinese history, we talk about death all the time. But after the Western medicine came in, people no longer have a family member die at home and things change. So I think through the education, we are able to serve our Chinese community better. This one is the 3 coming up topics here for Heart Cafe. You can see 3 of them, and advanced care planning and actually workshop, help people how to complete advanced healthcare directive. So for the first part of our partnership with UCSF, we find out there's several things we actually can focus in the community through our coalition. And we can share that with you later if you want to know more information. But I think the important part is the patient who participate there, we find out we can use the education tool, either the Heart cards or our materials. If you like to have more of the materials, you don't download and print it out in black and white. You can simply contact our office. We will be more than happy to send it to you, our booklet. For instance, conversation project, we can send it to you, just contact us because we prefer to see the colored full booklet there instead of printing in black and white. It is more attractive that way. And this is a few of the coming event. You can take a photo. Hopefully you can help your Chinese speaking clients to get on these different classes here. It will be hosted in both Cantonese and Mandarin. We don't have an English one for this. That's another one about the Heart Cafe. And people who come into the Heart Cafe through support of AARP, they sponsor us. you will receive a free heart-to-heart card, a deck of a card, once you complete the survey for us. This is the one of the 1-year program we started this year. It's called Redefining What Matters. And this is really exciting program here because it took us a while to invite 4 of very outstanding Chinese-speaking doctors. One of them, probably you're already aware, is Dr. Cynthia Pan. She is from NYPQ, and she provides some wonderful presentation during our 15th anniversary a few months ago. And also Dr. Huang, probably people already heard his talk because we invite him coming to our anniversary as well. And Dr. Lu is from China. And we have a psychiatrist, Dr. Ma. He already provided training early this month. Because they are all from different countries, so we have to find the time, the best time for them, and we do a lot of repeat. Hopefully we'll be able to have that upload to our website so people can benefit from that. All those talks, the 1 year, once a month talk, is all in Mandarin. And we are looking for funding, see if we'll be able to have a subtitle done so people can have an English subtitle to understand about their talk. I can guarantee you, because I heard all of them, I know all of them very well. Their talk is amazingly good. So, and the last one I want to mention is another new program starting last year. It's called Mindful Self-Care for Caregivers. We start this program, start with caregiver owning, but because the request from the community, we decided to have a mindful self-care just for Chinese American, because people might not label themselves as a caregiver for their loved one, but they also went through a lot of stressful situations such as COVID-19. So we open to the public, and we have people from different states, different countries to join us. We even have a mindful self-care for our health providers as well. This is a partner program with Zen Caregiving Project, used to call Zen Hospice Project. So we have about 6, we will add another grieving topic here for our 7 weeks program. And it's a year-long program. So before I introduce Dr. Sudore, this is my last slide. So our continued goal for the community is listed as follow here. And I think the most important part is we would like to really help the community in general to understand really how to have a better communication among us with our family member, our patient, or our health provider. But I think the most important part is how about ourselves. Through the conversation with ourselves, you understand the life and death. That's the best way before you'll be able to communicate with your loved one who facing the end of life. I think without we understand our wishes and talk to ourselves, I think it's hard for us to really help our loved one facing this journey together. So during this 15 years, we work very closely with our partner agencies and our partner members. One of the very outstanding partner and leader is Dr. Rebecca Sudore. We have been using her AHCD, simple AHCD form in the community for thousands of copies has been shared and printed there. So I'm very happy to and honored to introduce Rebecca Sudore from UCSF to share. And I'm going to leave this stop sharing so Rebecca can start to share your slides.
I would say before I share my slides, I think I was so thrilled, Sandy, that you invited me to join you just to speak for a few minutes about some of the things going on in DGIM, because it really does allow me to thank you so much for all the help that you've provided us and so many people from around the country. I don't know if people on the phone can tell, but whenever I talk about Sandy, I basically say that she's a force of nature. You just have done so much. And when I think about, you know, a lot of the work that is being done in advanced care planning often happens within like the walls of a clinic or a hospital. And Sandy and her team have really done the hard work to just get out in the community. And I know that you have like personally one-on-one touched like tens of thousands of people. It's really amazing. So just to say too, folks, working with her and her team in terms of translation has been really great. And so I highly recommend that as well.
Thank you. We do have a wonderful volunteer team. So it's not me, it's our whole team. So please go to our website.
All right, well, let me share my screen here. I'll pull up my slides. So I am going to talk today about prepareforyourcare.org and some of the easy to read advanced directives that Sandy was talking about. And just sort of taking a step back and really focusing for this talk on some of the work that we're doing in the DGIM clinic. But sort of taking a step back when we think about sort of adapting materials for different populations, there's something called the cultural adaptation model. And this is really sort of coming to these things with a lot of cultural humility and finding out sort of very first and foremost, what does the community want and what do they need, and getting their input. We do that, and we do sort of another sort of level of translation. We've been using the UC system translation system. Then we'll go to community organizations, and I put the little asterisk there for community organizations like the Chinese American Coalition. So you can see every place that we have asterisks are where the Chinese American Coalition has really provided input. So we'll get the translation, but that doesn't mean that the translation, even though it's done very well, doesn't have all of those cultural nuances that Sandy was talking about. And I think that that's really where her team can come and really help figure out not only just to do a straight translation, but really transcreation that pulls in that cultural adaptation piece. We then take that and go and do user testing. We find out all the things that we need extra help on or things that are confusing. We'll take it back to both, you know, professional translation and in other community organizations like the Chinese American Coalition. We'll do another round of user testing before we sort of get to the final product. So you can see it takes a lot of sort of time and effort to really do this right. And I think, again, that's where the Chinese American Coalition has really sort of helped so many other organizations go through this complex model. So many of you do know about our easy to read advanced directives. So they are in 10 languages in California. We worked with the UC Hastings School of Law to make sure that they're legally valid. They're in English and Spanish for all 50 states. Currently for 5 of the states with the most Chinese speaking people, so 5 states, but that's increasing over time. And we've done randomized control trials to find that the easy to read form can double our completion rates because people can actually read the information, and that people, you know, overwhelmingly prefer an easy to read form over a standard form. And we find that this is really regardless of whether somebody has high literacy or low literacy or what their language is. So we've also learned that, you know, a form is a form, and I think that's one of the things from Sandy's work that you'll see. From the heart-to-heart cards to the one-on-one help with filling out advanced directives, people need a little bit more direction sometimes than just the form. So that's why we created the Prepare for Your Care interactive multimedia website. And just to say that this website, people can go through and do it interactively. These modules can also be played like movies that can be done in group settings as well. But in creating Prepare, again, getting back to that cultural adaptation model, we co-created these with culturally diverse populations. We wanted to make sure that the advanced directives and Prepare were easy to read, so it's at a 5th grade reading level, There's voiceovers of all content and closed captioning. There's really a range of different kinds of video stories. For example, whether somebody has the available surrogate or not, or people who have different decision-making preferences. And really, I think the cornerstone are that there are videos that model advanced care planning behaviors. So we didn't want to just say, hey, you really should choose a surrogate decision maker. We wanted to show people actually talking to their surrogate decision maker and how somebody might do that. So an example would be how to ask a medical decision maker, how to talk with family and friends, and then how to ask clinicians sort of the right questions. Very quickly, just tell you that the efficacy of this patient-directed program, and what I mean by that is, we conducted 2 randomized trials, and we gave these materials to patients. We did nothing on the clinician side. We changed nothing for the electronic health record. And we found in our trials, this is with diverse English and Spanish speaking patients, that at the end of the trial, 98% of participants reported that they could engage in some form of advanced care planning. And this was at San Francisco General. The documentation rate for this population at baseline was 8.5%. And at the end of 15 months, that would increase to 43%. So we have many different written materials, including the Easy to Read Advanced Directive and pamphlets. We have Making Medical Decisions During COVID. We have toolkits for these group movie events. And the things that we have in Chinese and that Sandy and her team have helped with are the Easy to Read Advanced Directive, the things for COVID, and our pamphlets. I wanted to tell you, if you don't already know, about sort of a DGIM-wide and population health-based advanced care planning initiatives that we've been doing since about mid-2019. So we wanted to look at the DGIM population who are 65 years of age and older, and that's about 9,500 patients. And we're also, that's in a large QI project that we've been working on with Leah Carliner and John Lee. And we're also looking at a subset of these patients who have serious illness. And those patients who have serious illness are part of a larger PCORI trial that's also happening at UCLA and UC Irvine. And so through these initiatives, we're doing different things. We're seeing which of these materials may help patients the most. So some patients are getting just the Easy to Read Advanced Directive. Some people are getting the Advanced Directive plus Prepare, and then some of those are getting the Advanced Directive Prepare and then access to a healthcare navigator. But all patients, regardless, are getting automated Epic MyChart messages and automated mailing messages. And so I think it was really important to both Leah and John that we make sure that not only are these letters going out in English, but sort of to the other sort of 8 or 9 languages that are in DGIM, and Chinese being just one of them. So I'm going to end here by talking about what's going on in DGIM, and you can see there's a little gold star there up in the corner, just to say I'm giving DGIM a huge gold star because you guys are doing amazing. So when we think about advanced care planning in our health system, there's documentation such as advanced directives and post forms. And population health has this thing called clinically meaningful advanced care planning, meaning if you're a clinician at the bedside, is there information in the chart that would help you make a clinical decision or to help families? And that includes using the .ECP phrase. So for all of you who are using the .ECP phrase, thank you so much, because when you use that in your notes, it pulls it all into the advanced care planning dashboard. There are advanced care planning notes and CPT codes, as well as the forms. So clinically meaningful essentially includes all that documented good stuff that you guys are doing in the notes. So when we look at all empaneled patients in DGIM who are 65 and older, again, it's about 9,500 people. At baseline, when we started, the advanced care planning documentation, either in an AD or a pulse, at baseline was 24%. And within this last month, it's up to 33%. But when we look at clinically meaningful advanced care planning, you could see the huge jump there from 31% to 56%. So again, you guys are doing great. And when we look at, when we look at people who actually have serious illness, so this is about 1,000 patients who have very serious illness based on some validated algorithms, we can see that the advanced directive rate has gone up to 48%, but then look at that clinically meaningful advanced care planning is up to 82%. So for this talk in particular, we wanted to see how Chinese speakers are doing. So when we look at all of the Chinese speakers over age 65, that's about 802 of them. Again, the advanced directive documentation rate about 33%, but look at that clinically meaningful advanced care planning is 66%. And if you look at those Chinese speakers who have serious illness, oh my goodness, look at this clinically meaningful advanced care planning. It's up to 97%, and the advanced directives up to almost 60%. So again, I just want to say kudos to you and to all of the providers that are taking care of Chinese speaking patients. You can see, however, that there is still some room to move here. And so I really highly recommend sending people to Sandy's Heart-to-Heart Cafe sessions. I also, my very last slide is just to tell you about some new cool things. So many of you know that the Cures Act goes into effect at the end of this month. And I was actually a patient advisory board that said, hey, when Cures Act comes up, does that mean that we can look at our advanced directive documents? And the thing is that patients will be able to look at notes, but they wouldn't necessarily be able to look at their advanced care planning documents. So we worked together in a large group, including people from the Mary Center and the Cancer Center and many people from DGIM. And at the end of this month, what will happen is for patients, when they go to my chart, when they look at what's in my record, right under immunizations, they'll see advanced care planning, and they'll be able to look at this page that will come up that will tell them if they have any documents on file, and they can review that. And it includes resources like the Mary Center, where they list things like Sandy's Heart-to-Heart Cafes, as well as the Prepare for Your Care materials. And so with that, I will end, and I'm happy, along with Sandy, to take any questions.
I think before I turn in back to Maki, I want to really thank Maki and Gail to work with us and give us opportunity to develop all those programs. You did a wonderful work here. I'm very looking forward for our coming years to go. Thank you. So back to you.
Thank you both. Yeah, I just wanted to make sure we had time. We have some time for questions if folks want to either unmute or put it in the chat.
I have a question for Sandy. Sandy, you recently published a paper. Do you want to talk about that a little bit?
Sandy, I think you're muted, and if you want to come back on video as well.
Did we lose her?
Okay, here we go. Okay. Well, I have to find that's several articles here. One is a research paper that we did for the hospice and palliative care medicine, and talk about the research we did for the Heart-to-Heart Cafe. And it's from several of the authors here, and from, I think 2 of them from Yale. Is that Yale?
I think so.
Is it from
Harvard,
Yale? Okay.
Harvard.
Harvard. I'm sorry, Harvard. And one of them from NYPQ, Dr. Cynthia. And the other one, I believe, is from Kaiser. So, and then one of our staff, Shirley Penn. So it took us about a couple years to complete the whole thing. And then it's been published. We're very excited. And also, we are starting working with NYPQ. They want to do some research paper by have this project working with the hospital patient, Chinese patient, using the heart-to-heart cards, either through the cafe or just play the cards at the bedside. So it's ongoing. We just get started right now. So the other one is article published in the economy, one of another several article. If you're interested, go to our website, you will find out. Yeah, so I'm gonna stop here. If anyone have any other questions.
Yeah, hi. My name is Philip Garcia. I'm a nurse on the transitional care unit at the medical center. And this question is for Sandy. During your presentation, you mentioned that families would not want their family members' body to be touched after up until a certain period of time after they pass. And so I recognize this and I respect it. But I do find that you know when the provider does have to come in and confirm, there is often there's a lot of apprehension from the family for even the provider to take a listen to the heartbeat, and it's frequently just very challenging. Like when it does happen, it's challenging to communicate that this is something that we medically have to do. And also as a nurse, after the patient passes, I have to come in there and I don't have to take off the IVs and disconnect everything, but I do have to turn off the IV machine, the IV, I'm sorry, the Alaris pumps and the IV pumps and such. And of course, then there's apprehension from the family that I'm coming in the room and I'm doing stuff. So just with that background, and like, how would you suggest approaching the situation, just so it's not so so the family doesn't think that I'm disrespecting their wishes, and how would you approach, or how would you explain it to a family member that this is what we have to do medically without saying this is what I have to do medically? I just don't want them to think that I don't care about their wishes and their values.
Thank you, Philip. I think you asked a very, very important question here, that it happened all the time. That's the reason we really appreciate the coalition model here, because we work with the health providers. You're doing your part in the hospital setting or hospice setting. We're doing the community. So what we do is in the community outreach, we always remind the family, or through the one-on-one consultation, we'll tell the family member, you need to work with the medical team. Let them know the patient's religions, the languages, particularly if you have special wishes, such as not to touch the body for 8 hours, if possible, then we will let the family know. If it's all by, we call, because they are Buddhist, we'll say there's all karma among the patient and the others. Because if the hospital have extra room, bed, you'll be able, mom can stay here for up to 8 hours or 4 hours or even a couple hours. If they don't have a room, a bed for the patient, they did the best. But you need to talk to them way ahead of time before the patient die. So family member knows that, and then the team will know, have a notes there and put in front of their chart. They will know what to do, what to expect. Another thing is about to remove a tubing or any of the attachment. Family member will understand. You do the best you can, but something you have to do, you have to do. To pronounce death, use a procedure there they have to go through. They will respect that. We just try to be as gentle, as sensitive as possible. I think that's what we do. And during the work group like this, the workshop with our health provider, we do the same thing. We answer the question. It's not because the Chinese family member try to make a big noise, try to fight, to do whatever they think is the best for the patient. It's because they have a fear, they have a trust issue there. Once they understand you are on their side, we work as a team, this kind of a struggle will be much less there. So sometimes we will get a call from the hospital setting, ask us to almost like a bridge. We will have a volunteer from CACCC working with the family member who can speak the Chinese, understand the culture. I think that can help them because they know we are volunteer. We are not staff of the hospital. We are really here to support both sides, try to make everybody understand. So I don't know if that's good it's an answer for you. And you can always call us or email me, okay? And later on, I will give you my contact information at the end. Is that okay, Philip?
Yep, that was very helpful. Thank you so much.
Good, thank you.
So the website for CACC is on the chat there, if people want to look it up. And Sandy, I was just hoping that maybe it's the last minute, but you could talk towards the issue that you brought up at the very beginning about family members that we're often talking to the adult children of family members, and how to navigate that that dynamic of not wanting mom or grandma to be, to know about their prognosis, diagnosis, etc.
Actually, I have a question for Dr. Sudore, and I just want to know, do you have any data related to the impact of your prepare program or documentation rate to the final results of the quality of care or quality of life for the patients, and also some economic influences in this part?
Yes, so I want to make sure that Sandy gets to answer her question. I think you're on mute, Sandy.
Yes.
I'm happy, whoever that was, if you want to email me directly, I can get you the information. But Sandy, maybe you can answer that other sort of important question about what to do about people who don't want to inform their other family members.
Yes, okay. And before I do that, I want to make sure if I'm able to share my screen, because I like to give my contact information if it's possible.
And I just put
Can people see it?
I just put my email in the chat also.
Okay, good. Okay, can people see my screen here?
Yes.
Yeah? Okay, so that's my contact information, okay? Yeah, to answer the question here, Maki, is this is a very common request from the family member to not to tell to the patient about either the diagnosis or their prognosis. I think the easy way to think this way is we talk briefly about the cultural issue, because we are family is a unit, not individual. So we know what is the best things for me to do to the patient. But because we work with the family, we want everybody to be happy. So what we to do is ask the family member that what's their biggest concern, and provide the education, even though this is not the best time to do to convince them about what is the better way to help the patient. But we do our best to work with them. And because we have a virtual conversation now more often, normally I will strongly suggest call for a family meeting. Because when you call the family meeting, you will find out it's not all the family member want not to hide the diagnosis or prognosis. So they're going to have some conflict there. And we as health providers look ourselves as almost like a media to work with the whole team. And then sometimes the patient will say, I want to be there too. So every family, they have their own dynamic. We don't know. We just have to ask and offer the support. And then CACCC is the partner of UCSF. We are more than happy to be part of the team if it's needed. And we can talk offline and then try to explain the reason why family have this request. It can be challenging, but definitely it's doable. We saw so many family members finally realize and then thank the team that provide them opportunity to say goodbye to their loved one, and without feel guilty or feel it's not doing the good job. Because I think the worst story I can share, I still remember, it's been 30 years now. No, 20 years, I'm sorry. It's a few years before the CACCC. One of the family member who came to my focus group and cried nonstop for at least 10, 20 minutes is because she feel regret to saw the last moment of the father pass, went through the CPR, and then it's very, very sad situation there. And she saw that, she witnessed that. Unfortunately, it's under her insist, force the doctor to do the CPR, even the father already in their last moment, okay? So this kind of guilt feeling let me not be able to forget, because she told me, she said, Sandy, every time I close my eyes, I think of my dad. I saw the last moment of my dad, his face, painful and fearful. I really think she didn't deserve that, because she didn't know. She didn't know. Try to be a good daughter, try to save my dad. This is the result. And that was 20 years ago. And I really think more and more Chinese community realize that, so they can make that decision for themselves. That's the reason we say to help the ACP, people like Dr. Sudore, you really work hard on the community outreach besides working in the hospital. That, I think, is make the big difference. Why California can do such good job in ACP promotion than other states, because we've been here for more than 15 years now. Education does count, it's powerful. So, thank you.
Well, thank you both. So the contact information for both of them is up here, as well as the website. And so we, like, as we mentioned, UCSF is partnering with CACCC, and DGIM in particular, we are partnering with them. And so we have a lot of upcoming events that you will be able to see on that website that you can point your patients to as well. And feel free to email me as well. So thank you so much.
Thank you. Thank you, Maki. Bye, Sandy.
Thank you, everybody.